I had a tough time after lunch, so let's try to be alive. Now, thank you for the opportunity to share with you about our experience. What is important for me in these 2 hours is really to try to share, because it's a new disease, we already said, and we have made a lot of mistakes. And to be honest, with the visit of today, I'm impressed by how much you are much more aware about the problem, even if you don't have yet our situation. And for sure, we were not so aware, and we were not so prepared in Italy, and that's why, unfortunately, we are having this situation now. And we were not prepared, especially in terms of PC, infection prevention control. This is clear. Even seen today the hospital and the isolation center, I was impressed. We were not at, 3 weeks ago, we were not at your state of preparation. So, voila, just a small update. I think you are all very updated about the situation. So, as you know, it was declared as pandemic. This is now the situation all around the world. So, it's really a pandemic, and the epidemic has evolved from the blue is China and the red is out of China. So, as you see, the Chinese wave is almost over, but now the European wave is there. And let's cross finger, hopefully we will not have the same situation in Africa, but we need to be prepared. This is Africa, this is yesterday, but maybe there is already some update. So up to yesterday there were 9 countries with at least 1 case reported, and so far 2 places showed a local transmission. So it was Algeria and Cameroon. But then someone told me, or in Senegal as well, yesterday was demonstrated the local transmission, you told me. So it means, and when I started to do this preparation less than 1 week ago, there were 3 countries affected in Africa. So just to say how the situation is evolving fast. I will go a bit through all the steps, starting from the point of entry, but since we have already discussed a lot, I will go a bit fast about the point of entry, trying to concentrate only on the things that we didn't mention yet. And what is also important, that if you go on the WHO website, you will find every possible guideline, fortunately, and it's very well done. The thing is that then we need to adapt to our context. For example, in Italy, for certain things that I'm going to share with you, we could not adapt exactly the guideline. We have to adapt, and also we have to adapt during the pandemic, the epidemic, because at the beginning we had few cases. We could really put in place whatever was recommended by the WHO. But for example, now with this quantity of patients, with our resources, we had to adapt the strategies, because we could not cope anymore if we wanted to really do everything as it was recommended by WHO. So the effort here today is think about each context, because we all come from different contexts, and think how we can adapt the WHO recommendation to our own context. Okay, point of entry. So at point of entry, we don't have to manage so much in terms of clinical work, because as we say already yesterday, the day before, at the point of entry, we are not supposed to conduct any physical examination, and normally at the point of entry, we don't really have so much in terms of equipment to do so much. But what we have to do is to detect, to manage from what we have, and to refer immediately any ill travelers with suspected infection. And we have to do it in a safe way, and this is essential. First mistake that we make in Italy, it was at the level of the hospital in terms of infection control. If you see the epidemic in Italy, the clusters are not in the community. It's not like in China that you had big families where you have all the cluster. Our cluster in Italy were in the hospitals. It means that the hospital themselves, they were like an amplificator of the disease. And this, it's very bad, I have to say. And that's why it's very important that you are in time to strengthen up your infection prevention control. So to be safe is the first for the healthcare, so for ourselves, for the patient, and for the other travelers. Uh, okay, at the point of entry, we have to detect, we have to assess, isolate, refer, and report. These are the steps that we have already seen. So I will go fast on this part. I will concentrate mainly what we have to do at the level of the hospital. So detection, we already said the detection can be done by self-reporting, person arriving telling that he doesn't feel okay. For the slide, I will share the slide. So if you want to take picture, you are free, but don't worry because I will leave the slide if you want. So the patient self-reporting is illness with visual observation, even though this is very difficult as we saw yesterday, and their temperature measurement. And we already discussed. These are some photos taken in Italian airport. So as you see, we have also this thermoscan that we have seen here also. So what is just important is to keep the distance and to try to avoid the contact with the persons. So once we have detected the ill traveler, maybe this seems something very maybe not useful, but it's really important to explain the people, because I can tell you in the airport some people is scared. So because if we don't explain if someone has fever, for example, if we just take the person and we take him away in the isolation area without explaining to him, without explaining to his friend around and to the other passenger, other people will start to run out. It will be a chaos. So we always underestimate a bit this part of explaining the person and explaining the people around. I'm telling this because many times we don't have enough human resources, and the one that we have, we use it for what we think is the most important thing, so to take care of the patient, of course. But let's consider when you plan your stuff to have someone really to explain things to the people, because this will make your life really easier. And then, as we saw already, we bring the person in the assessment place, in the isolation place. At that step, what we have to wear in terms of protective equipment. We know that this virus is transmitted by droplets and by contact. So this is what we have to wear, whatever protect us from these two ways of transmission. So our eyes, our mouth, and for this is enough the surgical mask at this step, and then the hygiene and the gown and the gloves, of course. So this is the PPE required at the point of entry and also in the outpatient department. So we don't fortunately require the heavy PPE, let's say, and at this step we don't require the respirator, because the respirator are required whenever we have airborne procedure. So when we intubate the patient, when we do a bronchoscopy, so whatever procedure where we really have the risk of airborne, so to create an aerosol and then to inhale the virus. So, but these are particular situations that we don't see at the point of entry. This is the situation at the hospital level. Voila. Second thing is to assess the patient in the point of entry, and the assessment we saw already yesterday cannot be by a physical examination. It's just with our eyes. So we just can take the temperature, we can see the respiratory status of the person, so if he's breathing well or not, if he cough or not. But at this point, we don't do any physical examination, even if we have the PPE, because we don't have the structure, we don't have the facility for that. The second thing is the history of the patient. But for this, I want to share another big challenge that we had in Italy. At the very beginning, when we didn't have the big epidemic, we were just screening people coming from China. But China is quite big, you know. So at the beginning, we were saying, okay, just the people coming from Wuhan, so the small region here. All the other were not considered at risk. Because the problem is the case definition is quite vague in terms of epidemiological link. They say that we need an history of traveling in area
where there is a reporting local transmission. But as I say, in China it was not really easy because at the very, very beginning, okay, it was Wuhan region. But then the virus started to spread, so we start adding new region to the case definition. And the same in Italy. At the beginning, the high risk was considered this region of Milano, Lombardia is called the region. But now all the region of Italy has at least one case. So what we consider area at risk? For you, for example, at the point of entry in Africa, what you now consider as region at risk? All over Europe, Italy, France is not easy. So when we talk about epidemiological link, now it's becoming really difficult. And this is really the challenge because if you start to consider in the case definition all European arriving, it becomes huge. So you are very sensitive, but of course you are not very specific, and the risk is that you will have a lot of people. On the other way around, it's very difficult to select at this point of the outbreak which country, which area to consider at risk. So this is an internal discussion that you have to do, and of course following the epidemic's trend, but it's really difficult. The epidemiological criteria is not helping us in this moment. Really, what if you think what you will consider area at risk now? When you have for example, if you have a Greek person arriving at your hospital with fever, you will consider the person suspect, yes or no? Someone say yes? Yeah, well, there is no answer. So just to say that we have to think about it, because this is not clear, and we have to decide what we consider as epidemiological criteria. Probably at the beginning we made the mistake to be too strict. We consider only Wuhan area, but the virus was already spread all over China, so probably we made a mistake. At that time we should have started earlier to consider all China as potential area at risk. Okay, once we have defined that the person is suspected because he has symptoms and because he comes from what we think is an epidemic area, so we already see, we refer as soon as possible to the healthcare facility, and we report the case. But waiting for the transport, we have to isolate the patient, and this we already discussed a lot yesterday. So these are the steps that we need to do with the suspected patient. The one I put in red are the ones that we can do at the point of entry. So what we can do is to at least recognize the severe one. If we think that a patient is in severe acute respiratory illness, so we have to be faster, because of course it can be cough confirmed or not, but still the person needs to be referred fast, and we will see what we use normally as parameter to define acute respiratory infection, to try to be fast, and also to train the people at the point of entry, because sometimes, as we say yesterday, we don't always have a doctor. Maybe you have a nurse, so it's important also to train these people to detect severe cases who need to be referred immediately. Of course, infection control, and I put in yellow early supportive therapy, because I don't think it's feasible in most of the point of entry, but in some might be feasible. All the rest we are going to see later are the steps that we will do at the hospital level. So take the specimen for the diagnosis, to manage the different type of clinical presentation of the patient. Voila. So as you know, we can have several presentations of this disease. Fortunately, in most of the cases, the illness is uncomplicated. So really, most of the cases that we saw, even in Italy, that we have a quite old population, still we see 80%, even a bit more, who arrive with mild symptoms. So we manage many of them at home. We don't even admit them. Then we have some with pneumonia, can be mild, can be severe. And then we have some with a very acute respiratory syndrome, with sepsis or with septic shock. So these, of course, need to be admitted, and many of them need intensive care. And we will see how we follow them. So at the point of entry, we are still at the point of entry. I think in some place maybe there is a possibility to give oxygen and to give IV fluid, but I think this is quite rare. So if possible, I think this is the maximum which can be done at the point of entry. So if some structure have the possibility, why not, can be a good idea to have at least these two, these two possibility to provide oxygen and fluid. Okay, then we transfer the case, and the transfer should be fast and safe. This is the most important. To be fast, what is super important is to have already identified the referral structure. So when we have the patient, the pathway need to be already established. No time to make phone call, and this is essential in the contingency plan, to have already all the people identified, all the structure identified, and to know what to do. Don't lose time to create something when you have the patient. This is essential. Use predetermined transport route, and also we didn't mention so much, but in some country there might be security problem also related to other stuff. I was thinking to Nord Kivu, for example. So also sometimes consider the referral route, also considering other aspects like security. And then safe, as we say, with the IPC procedure. This is a picture of our hospital. So once the person, our airport, when the person was considered suspect, there was an ambulance. As you can see, most of the patients, fortunately, are not in very bad state. I mean, they walk alone. That's why sometimes, if an ambulance is not available, we can even consider normal vehicle. I mean, again, it depends on the resources. Of course, the ambulance is better, also because keep the separation in between the driver and the patient, but consider also that most of these patients are okay. They can walk, they can be transported by a normal vehicle. Okay, and just small things about the protection of the staff who do the transport. So the person who accompanied the patient should have the same PPE that we already mentioned. So contact and droplets means, again, eye protection, medical mask, gown, gloves. Okay, one pair of gloves. The driver normally doesn't require any protection because it's normally separated if you have the ambulance with the separation. Otherwise, you will need the same PPE. And the patient should always wear the medical mask. So this is the PPE required during the transport. And the ambulance, of course, should be cleaned and disinfected. This I think you already saw yesterday, so I go a bit fast. There is no special disinfection. The chlorine is fine. The only things, of course, need to be done after each patient, after each transport. Okay, and what about the people who travel with the person? Because this is also a big problem. No, we have, for example, a plane with the person with a very high suspicion. What we do with the other? So I can share with you what we did with some of the patients with the higher risk. For example, one plane was completely transferred to a military place that we had in Italy for quarantine. Because the patient had a high suspicion, and in fact it was positive then. So all the patients traveling with him, we didn't know what to do. It was at the beginning, so we put all of them in this military place, and every day we visit them there, and for 2 weeks they were there. Fortunately, all of them except one, they were negative until the end, so at after 14 days they went home. One of them, during the monitoring that we were doing each 2 days, they came out positive. So one of them was positive, so we admit him in the hospital. So this is super important to take care of the people traveling with the person. Yeah, go ahead. Ah, yes.
Yeah, I was just asking, were they in one room or they're in different rooms?
Sorry.
Those people who were in the plane when they were at the military place, were they in one isolated room or in different rooms?
So they had separated rooms, but then they have a common space. But it's a good question because in fact many of these questions they don't have an answer yes or no. It was just a discussion. We were thinking that they were all in the same situation, and it was also very difficult for them. They were coming from China, they were super stressed, so it was decided at the end to give them single rooms, but they could share some common space. But this is as a pro and cons, because for example, when one of them became positive, what we had to do, we have to restart the quarantine for everybody. So the quarantine was not just 2 weeks, but was longer. So we had to wait the 2 weeks after the second one was confirmed. But this was our things. Other option that we put in place after that were like a home isolation at home. We tell the person stay at home, we explain why. Of course, this is not, safe 100% because we cannot put the police, so yeah, we have to trust the person to explain, but then if the person wants to get out, they get out. So, pro and cons. If you have the possibility, you can offer an isolation place. For example, France had a similar situation and they decided to put them in a hotel. They pay for the hotel for 14 days and they told them to stay there in their room all the time. So it's a decision, and it's also a decision based really on the risk assessment of the person, because if then of course if the suspected case come out negative, there is no reason to keep them in. Okay, so according with the, sorry, go ahead.
Ici, hein? Ok, merci. En fait, c'est par rapport, disons, c'est toute personne qui répond à la définition des cas, peu importe son état. C'est cette personne-là qu'on doit tester.
Okay. Yes, so you are right. According with WHO definition, yes, all the suspect cases which fit the case definition should be tested. And this is what we were doing at the beginning. Now we are struggling with this because we are in a flu epidemic in Italy. The symptoms are super aspecific, as we saw. So whoever arrived with fever, we should test, in theory, because fever plus epidemiological link, now we consider all Italian as possible epidemiological link, means that we have to treat all the flu, all whatever fever, and so we don't have the capacity in terms of lab. The lab people are really getting crazy. They are doing a number of tests which is huge. They don't. So now we are in this moment that we have to decide, and we know that this should be done. This is the right answer. But we are in a moment in we are discussing what to do because our system doesn't cope anymore with this quantity. So I just share with you some possible idea, but there are no, as I say, right or wrong. It's just a decision. So you can decide that for the very mild cases, you just tell them, you go home and you stay isolated for 2 weeks. Maybe it's useless because maybe you are negative, I still don't know. But just to avoid to overwhelm the system, you can tell the mild cases, go home, stay at home. If you feel worse, you come, but otherwise you stay home. And this is a possibility. And you test only the one with pneumonia, with severe respiratory distress. Saddest proposal was to test according with the age, but this is really even ethically very, very controversial. So, well, as I say, I don't have the answer. Just consider that something can be done when you have the capacity, and then when you run out, you have to adapt. So, in this moment, we are in this situation in some region of Italy. Second question was, which patient need to be admitted in the hospital? Well, this is a bit easier, but again, at the beginning, the very first positive cases, we admit all of them, even if they were very mild, because it was something new, we didn't know, we want to keep the PCE as much as possible, so we have admitted very mild cases who fortunately had a super mild disease, and it was really like a flu, and then they were at home after they became negative. But now, for example, is not the case again. Now we don't have the beds to admit everybody. So now more and more we say, if you have a mild disease, you stay home. One possibility is to have some mobile team who goes to visit the patient, because we don't know, they can get worse during the time. So we should keep some monitoring, at least by phone, or if possible with a mobile team going to visit them. But now, in this moment, most of the positive people in Italy are at home, actually. Even some politician, because we had also some politician who got infected, very famous one. Fortunately, is going well, and so he's at home. Just to tell you, that is very normal now to be kept at home. Of course, we take a risk, because again, we don't have the police to keep them at home. So if they want, they can go out. But again, it's a choice that you made upon your resources. In this moment, we try to keep the beds in the hospital for the severe cases. Well, this is, for me, the most difficult question that we are facing now. Which patients should be admitted in the intensive care unit? Of course, based on clinical symptoms, we will see later which are the clinical symptoms. It will be easier to take the decision. No, well, the one that in severe distress need to be intubated. But in some region in the north of Italy, we ran out of intensive care unit. So some doctor now is facing the difficult situation to decide, I have two patients, both of them need intensive care, what I do. And he said, but in this case, we are basing on the age. So if you are 80 years old and if you are 50 years old, I will choose the 50 years old. Well, we don't like, nobody like it. It's super sad. It's like in a war. So you choose the patient that you have more hope to save. It's not ideal, it's not what WHO recommended, of course it's not ideal, but it's what is happening now. And I want to stress this because we have to make all the effort possible to avoid to arrive at this point that unfortunately we reach. You are still in time to avoid this situation. Yeah, I think the last one is already answered. So what if the health capacity is reached, is overwhelmed? We have to adapt, as I already showed you in these examples. Okay, so let's say that the person arrived, we really suspect that can be a case, so we do finally the test, and I will have -1, and the -1 will be treated according with the symptoms, so if he needs to be admitted for other reason, he will be, otherwise he will be sent home. And if it's positive, we will manage him. But as I say, not necessarily at the hospital, because if it's positive but mild case, we will send him home with all the education, with all the material for him and for the family. But so it's not obvious that if you are positive, immediately you will be admitted at the hospital. How to do the diagnosis, I think that you already know, but we do swab, we do nasal or oral swab most of the time. They explain me, the lab people, the best is to do both and to put it together because we increase the sensitivity of the test, so it's good to do both. And it's quite safe. It's a procedure that we can do safely with the PPE that we already mentioned. It's well tolerated, so at least this is quite simple. It's not necessary to do prelevement of the lower respiratory tract. Normally, we don't suggest to do it, and this also WHO agree, because, of course, this procedure is more unsafe, is more dangerous in terms of contagiousness. So the sensitivity of the upper tract is already good, so we don't need to take unnecessary risk. Unless the patient is intubated, in this case, we can also take a tracheal aspirate. Anyway, in this case, is already intubated, so we can do it. And we are actually doing it for monitoring, not for diagnosis, but for monitoring of the patient. The test is a PCR. At the beginning, we didn't have the PCR. We had it quite soon, but at the very, very beginning, we didn't have a specific PCR for the COVID, the new one. So we had the pan-coronavirus PCR. It means it was a specific. So it told you which coronavirus, no, a coronavirus was positive, but it was not necessarily the new one. Now we have, of course, the specific one, and I heard that many of your countries have already this. There are countries here that they don't have a lab able to perform the PCR for COVID, or all of you are, go ahead.
We send our specimens to South Africa,
Okay.
NICD for Lesotho.
Lesotho, Zimbabwe has it? Okay, so of course this, you have your own, you're sent to South Africa.
We do, but we're still not validated, so we further send the
Okay.
sample to South Africa
Yeah.
for validation. But otherwise, they are done, but at a small scale at present.
Yeah. Yeah, now I'm asking this question because, of course, coming back to who to test, you have also to consider where is your lab. If your lab is in your hospital, like we saw this morning, of course, it's much easier. If your lab is in another country or in a city very far, also this is something to consider when you make a decision who to test. Okay. So then other lab tests to consider, because now, of course, we are all focused on the COVID, but there are other diseases also. So we normally we should do, even before to have a confirmation, a complete blood count. We do a sputum for bacteriology and also for other viruses and for TB in endemic area. And we also do blood culture normally, so to try to identify in case of sepsis or bacteremia immediately. And I think in many of African countries it is worth to do here a malaria test, because of course a person comes with fever, symptoms are specific, so I would add for most of your country a malaria test at the entrance. Okay, let's say that finally we get the result. Our patient is positive, okay? So we had the suspect case, we test, we did the other blood test, but this test came out positive. So what we do? We have to evaluate now him clinically. So is it a mild form, so just fever, cough, sore throat, fatigue, but nothing serious, no respiratory failure? It is moderate, it is severe, and for severe we consider ARDS, sepsis or septic shock. So it's super important identified as soon as possible this. Why? Because this can change the prognosis. So if they have one of these, it will be essential to start an antibiotic treatment as soon as possible. To start resuscitation if it's necessary, to start fluid, and to do a mechanical ventilation if it's needed. So this is very important. So how we identify the severe cases? Of course, normally we do just a normal X-ray. Many cases show a pneumonia. It's quite atypical. I don't know if you saw some of the picture that they already published. Both the X-ray and the CT scan are quite atypical. It's not really something that you see and immediately you recognize. Yeah, go ahead.
Sorry, I just had a question on the last slide regarding the ARDS and sepsis when they have the severe acute respiratory infection. Which antibiotic is recommended or would you use in such cases?
Can I answer a bit later?
Sorry.
If I don't,
Sorry,
you remind me,
okay.
because we will reach that.
Okay.
Yeah. So we have a patient with pneumonia showed at the X-ray. You see, I just put this just to show you that these are actually bacterial pneumonia. This is influenza pneumonia, but they could look like this. So it's not very helpful from an etiological point of view, but in this case we already have the test positive, so we know it's positive. This was a MERS case, and this is our COVID. So just to show that they are quite similar, all the radiological findings. Voila. So it's important, even when we have a pneumonia, to recognize the moderate and the severe. And normally, this is something that we can do everywhere, even in the district hospital. So the respiratory rate, the saturation, and to see if the person is in severe respiratory distress. So if he cannot speak, if a neurological status is alterated, and if he uses the accessory muscle. So it will be essential, especially at the district level, to well-train the people to identify severe pneumonia. And also consider that in our experience, we saw that some patients arrive mild. And then it's at day 5 that they start to deteriorate. This is quite now it's quite common. So for example, we had the couple, the first Chinese couple we had. The beginning, the husband was very sick. He was already advanced. And the woman was fine. We admit her just because they were together and it was the beginning. And then he started to get better and she started to get worse. So they had exactly the same trend, but a bit not at the same time, let's say. So the day 5, it's really crucial. So just to say that you have to monitor the patient, because even if he comes in a mild situation, he might evolve. So it's very important to monitor. To monitor, so what is most important, to clinically monitor to see if he has cyanosis, if he uses accessory muscle, if he has tachypnea, the neurological status, and to be able to detect an acute respiratory distress symptoms as soon as possible. Well, this is already done. Okay, this is a typical bilateral opacities, which could not explain with other reason. We know that the test is positive, and these are really the finding given by this virus. It's quite impressive. So the person at this point doesn't breathe. He needs ventilation, mechanical ventilation. This is another example of the same things. Of course, then you have also to run out other possible causes of distress, especially cardiological causes. If you have pulmonary edema, you should run out also cardiological causes of the edema. Then you have to run out sepsis. Sepsis is another complication which made the prognosis of our patient very bad. It's not always easy because sepsis is a continuum of severity, ranging from a simple bacteremia up to the septic shock. So again, we have to follow the patient, and the monitor should be done with the blood pressure. When the systolic one goes under 100, we have to start to be scared, and then to follow all the clinical signs of hypoperfusion, especially at the neurological level. And then one test which is extremely important is lactate. So if we have hypotension, sign of hypoperfusion, and elevated serum lactate, we are suspecting very strongly sepsis. I think you already know this SOFA score. So this is a score to identify as soon as possible a septic shock. But it's a bit complicated if you think to teach again maybe the small hospital. So what we suggest is actually this quick SOFA, which is shown to be as sensitive as the SOFA, but much more simple. So there are just 3 parameters, so the respiratory rate more than 22 per minute, the alterated mentation, and the systolic blood pressure under 100. So it's simple, it can be done wherever, you don't need any big equipment, but it gives you, if this score is more than 2, each one you has a point, 1, 1, 1. So if you have more than 2, so it means at least 2 of these criteria are fulfilled, this is associated with poor outcome of the sepsis. So you have to be strongest, let's say, in your management. Yeah, this is example. So here you have 1 point because only 1 of the 3 parameters are altered, 2 and 3, and the 3 is associated with high mortality. So another score, and this I wanted to spend a bit more time because this is what we use in our Italian protocol I'm going to share with you. Consider respiratory rate, heart rate, systolic blood pressure, temperature, and neurological symptoms. Each one has a score. You see 3, 2, 1, 0, 1, 2, 3. So if the total is 0, it means that the patient is normal. Then if it's 0, 2 is stable, 3, 4 unstable, and more than 5 critical. This, when you have a lot of patients, it can really help the triage to identify who need what in terms of management. So we found it very, very helpful because the person is evaluated maybe even by a nurse, because these are all simple parameters to take, and the person is assigned to a certain score, and based on the score, we know what we have to do. Here I put some extra monitoring if you have the possibility. So apart from what we already say, what is also very important is the urine input. We had several renal failure among our patients. And another very important is the arterial blood gas analysis. This we always suggest to do it, if possible, at least at the day 5, because as I said before, is the day where the patient normally gets worse. So it's there that we have to make sure that everything is fine. So we really suggest to do it at the day 5. Okay, so just because I stress so much how much is important the monitoring, just to underline that the good monitoring can be done with very simple equipment. We don't need, so just a pulsometer, if it's possible a monitoring. This again, I'm not sure at every level we will have, but at least in the referral hospital. And okay, to take the pressure, non-invasive blood pressure monitoring, and if it's possible, invasive blood pressure monitoring. Okay, so let's see now case by case what we should do. Let's start from the asymptomatic mild, the easiest. So we have already mentioned a bit. Not all of them need to be admitted in the hospital, but I think, I hope not, but if you will have a case, at least the first one, you will admit them anyway, as we did. But just keep in mind that if the number will increase, it's not necessary to admit them at home. In the hospital, they can stay at home, but in this case, really don't forget the education of the patient and of the family. This will be essential, otherwise we will spread the virus around. So we have to educate and also to provide the proper PCE to the family, the caregiver. So this should be ensured. The patient should not pay by themselves, the family should not pay by themselves. And then a clinical monitoring should be done, both in the hospital or at home, as we said before. Okay, so train all of them. So normally before to before to take a decision, what we do is we test not only for COVID, but also for other viruses, In Italy, we test for influenza because in this moment is the most common virus. But as I say, probably you will also add the malaria test, and according with the country, you can decide other baseline tests. You will monitor clinically, and what we do as monitoring, each 2 days we check the PCR. Well, we used to check it each 2 days. Now that they became too many, we just decided 5 days. So, but it will be up to you. What you have to know that you have to monitor with the PCR. So you have the first one, which is positive, but then you have to follow, because based on the PCR, we decide when the person is cured, and we can stop the isolation also. So at the beginning, we were checking each 2 days. We don't do as routine the serology, even if at the beginning we used to do it. We do it for some clinical trial. The Chinese has done some clinical trial, and we have done also when we wanted to understand what's happened. For example, the first Italian case, it was very strange because the guy never visited China. Apparently he didn't have any contact. So we were wondering how he got this virus. And then he mentioned that he had the contact with a Chinese guy coming back from Wuhan. Okay, so we found the Chinese guy, but this guy was negative. The PCR was negative. Very strange. We did also the serology because we thought maybe the PCR is already negative and is seroconverting, so the antibodies will be positive, but no, it was negative. So that's why we never had the case 0. We don't know how the virus entered, but just to tell you that we don't normally do as routine the serology, but it's a possibility sometimes when you have some doubt. And then in terms of diagnostic, most of the time in X-ray, it's enough for the mild cases. Sometimes we don't even do it now. So if it's really necessary, we do an X-ray for the mild cases, otherwise no. And for the mild case, we don't give any antiviral treatment. As we will see then, in the most severe cases, we are giving antiviral as experimental treatment, because we still don't have an antiviral for the COVID, but we are using the experimental one. Okay, then, as I say, to decide when to discharge a patient from the hospital or when to stop the isolation from home, we need 2 tests negative, 2 PCR negative, done 24 hours apart. So when the first one is negative, we repeat the second one after 24 hours. If they are both negative, discharge. So this is according with the WHO recommendation. Any question about the mild case? It's clear? Okay, now we have a patient who is stable, but when we do our score there, it's not 0, it's 1 to 3. So it has some respiratory symptoms. It's not very severe, but it's not even mild. So we see the patient and what we should do for a patient of this type. So in terms of PCE, we do the same things that we have done already for the mild case, but we add some tests. So we also test, I don't know if it's a problem for your countries, but for us, Legionella and pneumococcus are a very important cause of pneumonia. So we do this test on the urine, the antigen for Legionella pneumococco, and if we have the possibility, we get some sample, deep sample for the test also on the lower respiratory tract infection. And we do blood culture. The clinical monitoring is the same, but in this case, as I said before, it's very important the arterial blood gas analysis, especially day 5. In terms of monitoring, again, we repeat the PCR each 2 days. Again, this time is decided upon capacities, so you can decide to do it each 5 days, or it will be up to you. In this case, we do chest X-ray, but also CT scan. Normally, it's not needed to do the contrast. The one without contrast is enough, is quite sensitive, and it's helpful. So we don't need to do the contrast, so we don't need to care about the renal function, and it makes it easier. In this case, we are given antiviral therapy. And which one? So this is our protocol. This is not WHO. We decide for these cases to give lopinavir-ritonavir, the famous Calitra that you probably know because of HIV. Because some in vitro studies have shown an activity against coronavirus, so it can be used. Is a clinical trial. Many patients in China has taken this, so we still don't have the result, but is one possibility. Is a tablet, so is an oral treatment, quite easy to take. So if you have the possibility, this is what we provide for these not so severe cases. Then we give supportive treatment, antipyretics, rehydration, and in this case, we also give antimicrobial treatment. So this is based a bit on your epidemiology. What we do is a beta-lactamine plus a macrolide, normally, if we don't have some particular suspicion. Let's say that this is our routine. But it's a bit because of our epidemiological situation in the hospital, and because we try to cover a bit everything. But then each one can decide. The thing is that the antimicrobial treatment should be a wide spectrum one, cover gram-negative and gram-positive, and we are giving to everybody, actually. From not the mild, but from here on, we give to everybody, even if the blood culture is negative, because with this kind of pneumonia, it's quite easy to get an infection with bacteria, which will make the prognosis worse. So we prefer to cover all of them with antimicrobial empirical treatment. Okay, so the criteria for discharge is always the same for everybody. So 2 negative tests, 24 hours apart. Is this clear, this one? Just for you to know, I don't have experience because we are not using, but just for you to know, someone used chloroquine. They are using, we don't use it. For these cases, we use lopinavir, but there are now several clinical trials with chloroquine also. I'm just mentioning it because I think in Africa it's more available probably, but I don't have experience in this, so I don't know. But if you want to look for it, there are studies ongoing with chloroquine also. Okay, then we have a patient a bit more severe. So we are at score 3-4. So it's not yet the worst case, but it's getting worse. And of course, these patients, they are not their score on their face. They can change. As I say, someone can enter mild and then, unfortunately, progress toward a more severe disease. So it's not fixed. So that's why the monitoring is very important. So when we have a case like this, of course, the patient need a more intensive care, but we are still not at the intensive care. Here we manage still at the let's say internal medicine, infectious disease, or what you have in your hospital. So we have to ensure the strict monitoring, so even more frequent than the other patient, the adequate peripheral oxygenation, so to give oxygen, this is 100%. To use antiviral drugs, and I will tell you which one we use in this case, to treat the possible bacterial infection, so with empirical treatment, and then to see to assess the person, because this is someone who can evolve very rapidly and who can be in need of mechanical ventilation. So these kind of patients are the one that you have really to monitor it more strictly, because as soon as they evolve to ARDS, they need to be transferred to the intensive care unit. So again, PC strategies are the same. Microbiological diagnoses are the same. Plus, in this case, we also test for HIV, for Staphylococcus aureus, multi-resistant, because for us it's a big problem. I don't know if it's a big problem for all of you, but just to say that in this case where the patient present with these symptoms, is also important to exclude other possible comorbidities, and this will be based a bit on your context. It depends which are the most common comorbidities. So these are ours, but not necessarily yours. So for sure, again, malaria, maybe salmonella. So according with your context, if you have a patient who is getting worse, it's always important to keep in mind that it can be something else which is going on and is making the situation worse. The monitoring is always the same, but what we do at this point is always to involve an intensivist or depends who are your colleagues who work in intensive care. So already at this step, we want already to make the intensivist aware that we have this patient who possibly could be sent for mechanical ventilation. So it's important to involve them already from this stage. Virological monitoring, always the same. For this patient, it's important to do for this patient the PCR each 2 days, because we can see if the worsening is related to an increase of the viral load or maybe to something else. Because, for example, if we see that the patient is actually improving from the viral load point of view, so the viral load is coming down, but the clinical is getting worse, so maybe it's something else. So in this case, we should look more actively for something else. Well, we take for granted that the clinical symptoms are related to the viral load, which we are not sure yet for this virus, but knowing from the other viruses, we consider that viral load is related with the clinical severity. And in this case, we always do also an echocardiography, because as I said before, we cannot exclude that the pulmonary situation can also have a cardiogen cause, let's say. So whoever has the possibility at this stage, is always good to complete our diagnosis with an echocardiography. And from this severity on, as antiviral, we are using remdesivir. Maybe some of you know this drug because it was used as experimental drug for Ebola in DRC in the recent outbreak. So even for this one, in vitro, it seems that he has some activity against coronavirus. So that's why we are using it. Is IV, is 10 days injection. It cannot be given together with the lopinavir-ritonavir. So that's why we selected. So the milder patient, they'll take Kaletra, lopinavir-ritonavir oral formulation. The most severe, they take remdesivir IV. All of these drugs, I repeat it, are experimental. So we don't know if they are working or not, but we are trying. It's important to give oxygen, of course, to give antibiotic, we already say. And this is a big debate, steroid, yes or not. If you see the WHO guideline, they will say no. But even we had many meetings with them. It's really a debate. They say no, but. So let's say that in our experience, and also we talk a lot with some Chinese colleagues, and they had more or less our same idea, can be good to have a short corticosteroid treatment very early at the ARDS and short, finished. Go ahead.
Chiara, I was going to ask, it's controversial, but they've been using it in China, the mesenchymal stromal cells, stem cells in the ITU. But I think there's problems with getting permission to do that in European settings. But apparently it's been quite effective using the stem cells. Have you heard about this? Giuseppe is
I heard, but we didn't get, so I don't have experience. But I know that in China, yes, they use it. Yes, so there are some drugs, but again, we don't know this virus, so we are trying. But it's true that we are experimenting some drugs, some seems to work. In our experience, corticosteroid at these doses work. But we saw that they worked better when we give immediately, when the person starts to have acute respiratory distress, and then we stop fast. We don't keep it, we just keep it 5 days normally. And then we do the de-escalation. So, but again, this, I just want to tell you that is not a WHO recommendation, it's our experience and some Chinese colleague experience. So take it as it is. Voila, criteria for hospital discharge, as always the same, yeah, two negative tests. And we arrive at the most severe patients, so the score more than 5 or more. Sorry, it's a mistake there, it's not less than 3, it's more than 5, sorry. So this is the most severe one. This patient need normally to be sent for the mechanical ventilation to intensive care unit. And as I say, now we are really struggling to decide which patient to send or not. But yeah, these are the indications. So more or less, the management from PCE, microbiological diagnosis, clinical monitoring is always the same. It's just they need, of course, stricter monitoring, more frequent. They need actually continuous monitoring. From a virological point of view, normally because these patients are intubated, we perform the PCR on sample also in the lower tract infection, not only for the upper. We do CT scan and echocardiography quite frequently to monitor the patient. And in terms of antiretroviral therapy, we give remdesivir as for the other one. So it's a similar management from a medical point of view, but then they are intubated, they are mechanically ventilated. One hypothesis was also the ECMO, so the extracorporeal oxygenation, but we don't have big experience, and of course it's not very, very widely available, but it was considered. In terms of supportive therapy, the same things like, yeah, the same thing about steroid. So again, it's a debate, but it seems to work. And ECMO. For the rest is the same management. Well, this is a bit what we are doing, the protocol that we try to design based on the experience that we had. In an ideal world, you will have a facility to treat all these different categories of patients. In the real one, unfortunately not, so it's very important to rationalize the resources. Okay, do you have any questions so far? Go ahead.
Merci. On se croit toujours avoir beaucoup de connaissances, mais on apprend tous les jours. On a appris beaucoup de choses aujourd'hui.
Merci.
Moi, j'étais émerveillé parce que je suis clinicien. Donc, la partie, tout m'a intéressé, mais surtout la partie prise en charge médicale. Mais j'ai quelques questions, plutôt d'incompréhension.
Ouais.
La première, c'est, vous avez parlé de 3 critères de gravité ou sinon de l'admission en réanimation. C'était les critères respiratoires, hémodynamiques et neurologiques. Dans les critères respiratoires, vous avez parlé seulement de la fréquence respiratoire. Ouais. Alors que ouais. le SPO2, qu'on appelle aussi SAO2, la saturation artérielle d'oxygène partielle, est un critère très important dans l'évaluation de la gravité. Vous en avez parlé, mais seulement dans la surveillance.
Si.
Alors que c'est un critère très important pour l'admission en réanimation. Ouais. Ou bien candidat à une intubation, assistance respiratoire. Ma deuxième question, c'est par rapport à la radiographie. Est-ce que, dans votre expérience, parce que l'Italie actuellement a suffisamment de recul, je peux dire, pour nous nous donner des éclaircissements. Est-ce qu'il n'y a pas, à part le syndrome interstitiel sur la radiographie, il n'y a pas d'autres signes qui sont beaucoup plus spécifiques au coronavirus par rapport à l'ensemble des patients que vous avez reçus? Autre question, c'est par rapport au traitement antiviral que vous utilisez. Est-ce que vous pouvez nous donner une idée sur les résultats? Est-ce que c'est encourageant les résultats que vous avez obtenus par rapport à l'utilisation de ces antiviraux? Et la dernière question, c'est quand un patient est sous assistance respiratoire et qu'on est obligé d'utiliser le circuit central d'oxygène, est-ce qu'il n'y a pas un risque de contamination du circuit si le même circuit est utilisé par d'autres patients?
Ouais.
Alors, merci.
Ok, merci à vous. Okay, so the first question was about the monitoring. Yes, you are right. I have mentioned the respiratory rate, but the saturation, of course, is essential. I went a bit fast but actually, of course, we use it as a parameter. I was just showing the Q-SOFA because not everywhere there is a possibility to check the saturation, but if you have the possibility, of course, we are using it and we monitor with the let's say complete SOFA, so including the saturation, and we do the arterial blood analysis almost every day for the severe one. So yeah, so thank you for this remark. It's very important. The second question was about radiology. So radiology, to be honest, no, we don't have specific, we have very atypical, like the majority are interstitial pneumonia, but then we have this mix. The most common that we saw so far are these mix, infiltrate, like they look like bacterial, plus it's a kind of like if you have a viral pneumonia plus bacterial surinfection in terms of radiological aspect. So you have the both finding together. And we don't know, it might be that we have bacterial surinfection, but in some cases, all the bacteria tests were negative, so we think that the virus itself is able to give this mix finding, but it's difficult to say if this is really typical or not, because we saw really different patterns, and but I don't think we can say yet that we have really some pathognomonic sign from a radiological point of view. Sorry, the other question I forgot now.
C'est par rapport à vos résultats.
Ah oui.
Ouais.
Yes, about the result of the antiretroviral is too early. Honestly, in our experience, is too early. Some Chinese trials is a bit more advanced, and the best result that they show so far is with remdesivir. But as personally, it's too early because most of the patients are still on treatment. So really, it's too early to say. I hope we can say something. The only things that I can tell you really by experience that you can really see the improvement is really the corticosteroid in the very severe one. But in terms of antiretroviral, we didn't see like any amazing improvement immediately. But then in the long term, we will see. It's too early. Yeah. Is this? You have one more?
Dernière question, c'est celle du circuit d'oxygène.
Ah oui. Ça c'est vrai. Yes, it's true that when we use oxygen, then we need also a proper decontamination of all the circuit. And this is also a big problem because already we are running out of intensive care beds, and moreover, there is a timing needed for the decontamination, so which makes even slower, let's say, to free space for the other. But it's true, it's something that we have really to consider. Yes, it can be contaminated, the system, and it needs decontamination. Yeah. Thank you for your question. Yeah.
Thank you for the nice presentation. I have 3 questions. The first question is, of the patients who had coronavirus, were there any who were also already taking ARVs for HIV? That's first question. The second question is, from a clinical point of view, what was the clinical response of the patients who were given chloroquine? Then the third question is, of the patients who died, what was the proportion of those who died who were purely because of coronavirus and not because of bacterial infection?
Okay, so chloroquine, I tell you immediately that we don't have experience. I just mentioned because it's something that they have used, especially in some Chinese trial, but we, in Italy, we don't use yet, and so we don't have experience. So for this, I cannot answer. So for the first question, sorry, it was the HIV. So there were some patient HIV, but not on Calitra, not on lopinavir-ritonavir, but one or two, not so many. So far it's difficult to say. If this had an impact on the prognosis. And then among the one who died, the only things that you can say that is the age. Obviously, the age is the worst prognostic factor in the sense that more than 95 of the patients who died were more than 65, and with many of them more than 80. So the age is really for us the main prognostic factor, and as you can imagine, given the age, many of them, they have comorbidities, especially diabetes, hypertension, someone had cancer. So it's not really easy to say who died for the COVID or with the COVID. This is a big debate. It seems that the comorbidity play a role. In most of the cases who died, they had comorbidities or they were very old. Not really comorbidity in the sense of bacterial infection, but more chronic comorbidity. You see, diabetes, heart diseases, chronic heart diseases, and cancer, of course. But it's a very interesting question, and I think many trial will be done on that to see really which is the mortality related to the virus or not, because I mean we are I'm the first one that I think we should be prepared, but we cannot think it's Ebola. It's not Ebola, fortunately. So it doesn't kill like Ebola. It kills people who are weak, clearly, in our experience. And that's also why it was so bad in our population, because our population is much older than yours. And so the impact was worse, let's say, was very bad. Yeah. Other question? Sorry, I don't know who come first. Just one. I will come later.
En fait, je voudrais avoir des précisions. Existe-t-il des tests rapides de dépistage des coronavirus? C'est ça la question.
Well, no, unfortunately, we still don't have rapid tests for coronavirus. It's something that we are dreaming of because, of course, it will make life easier. The dream is to have a kind of gene expert for the coronavirus, but so far we still don't have. And talking with the lab people, they say that is not something so easy, that is not something we are going to have very fast. It will take still few months. So far we don't have rapid tests. Yeah. Go ahead.
So at the point of entry for this client, we don't do any symptomatic treatment. No drugs are given until the specimen are collected.
So at the point of entry, what we prefer is not to really give symptomatic treatment unless the patient is really severe and is an emergency case, to avoid to mask the situation. So as we already, I think, discussed a bit 2 days ago, if it's not a child with a high fever and if it's not really an emergency case, we prefer to just assess and don't give treatment, just to give the opportunity at the hospital level to assess well the patient. Even antibiotics is better not to give, but to let the patient arrive at the hospital so they can do a blood culture which will be more sensitive without any antibiotics started. So yes, we should reserve the treatment only for emergency cases at the point of entry. Yeah. Yeah.
I'm not sure, maybe I may have missed it, but then what's the disease progression like from maybe a point where someone has been tested until for the patients that have died so far? What period is it? What's the
so normally the average, let's say, it's 2 weeks more or less. So we have really this trend. So the patient arrives is normally quite mild, then it gets worse around the end of the first week, and then or died or slowly, progressively improve. And up to 2-3 weeks normally we have the negative test. Then it depends also a lot when the patient arrives, because at the beginning we had patient arrive in a very severe status, so they arrive already at the peak. So then we see a faster development. Now that we are a bit more careful, that we pick the person from the beginning, let's say, we see really this curve like that. So mild, severe, then or died or improvement up to 14, 21 days, more or less. This is the average, but more or less is what we are observing.
Okay, so if someone is not treated early, so they can die within 5 days on average?
They can die the 5th day, the severe, yeah. Other question? I don't know the order, but let's do this.
Thank you. Any cases of reinfection and any difference in terms of the disease progression?
So I didn't get the first question, sorry.
I was wondering whether there's any cases of reinfection, a second infection from
no,
COVID.
so far no. So far no, and the immunity question is still open. We don't know if this disease confer immunity for how long, but so far we didn't see reinfection. Yeah.
So my question is about symptoms. We have read some studies from China, like from their experience. So for them, one of the commonest symptoms, yes, it was fever, maybe like in 60% of people, but also cough was very common, maybe like in 40% of people. But yes, yet those are a kind of complicated cases. So like hospital admitted cases, not mild cases. So I want to hear from your perspective in your experience in Italy. What were the commonest symptoms? So I'm asking this question just to know exactly, to be a kind of having a response to the question you were asking, when to test.
Yeah.
Yes.
Yes. Yes, the most common symptoms are the one you mentioned, so fever, cough, and dyspnea, short of breathness. But it's true that we have to make the difference. So, first of all, at the beginning we thought that we could not have asymptomatic patient, but in fact we had. We had very mild and very mild, let's say not really asymptomatic, but very mild case. For example, the example I gave at the beginning, when we kept in quarantine all the travelers of the same plane, and we test them every 2 days, even if they were asymptomatic. It was just for monitoring. So we test them, and one of them came out positive, but the guy was like maybe he had a bit of a common cold, but really he was negative. And this for us is a kind of surprise, because at the time we were thinking that there were no asymptomatic cases. So just to tell you that when we talk about symptoms, we talk about symptoms that we we see and we have demonstrated that they are positive, but there might be cases without these symptoms. Because like this guy, we pick not by chance because we did the monitoring, but we never know if he was not in this group of people, we probably will never test him. And he was really almost asymptomatic, really like a common cold. So just to tell you that it's difficult to answer your question because we still don't know how many asymptomatic are there. The idea, but it's just an hypothesis, is that considering the speed of the spread of the disease, probably the asymptomatic play a role because we don't detect them and they spread. But it's an hypothesis we still don't know. Probably seroprevalence study will show this better. We can say that among the symptomatic, these are the fever, cough, and short of breathness are the symptoms that we see the most as well, like the Chinese. But we also know that there are asymptomatic, but we don't know how many, which is the percentage of them. Yeah.
Thank you so much for your presentation. I think this has given a lot of us some sort of information, skills, and knowledge to take back home as far as case management of COVID-19 is concerned. So having said that, you said you are moving towards not testing those mild cases. If am I correct?
Well,
yeah,
depends on the region.
Okay,
but like, for example, in my region, and in this, because I come from Rome, and from Rome down, let's say, we don't have yet so many cases, so we are still testing everybody. But in some region in the north, which is overwhelmed, they start to think maybe we should stop to test the mild cases, just to tell them to be isolated, even if we are not sure that they are positive or not. Yeah.
So my concern here is then what is the denominator when it comes to your statistics? So that's one. I knew China at a point to move away from testing, but they replaced that with a clinical case definition, so that they now like have lab confirmed and clinically confirmed cases, and that clinically confirmed was still part of the denominator. So I think as you go forward, we need to begin to think of that, So that's one. Two, quickly moving on to the experimental medications, those antiviral that you are using under monitoring emergency use of unregistered interventions, right? Mm-hmm. So now, are you also looking at it from a research perspective? If so, what sort of research design is in there, especially in the aspect of control?
Yeah.
Am I clear?
Yeah, very clear. So about your first comment, yes, you are right completely. So in doing this, we lose the denominator. By the way, the denominator is already very vague because, as we say, all these asymptomatic, probably they are in the denominator, but we miss them. But it's true that, yes, if the decision then it will be really taken to stop testing, we should replace, as the Chinese have done at one point, with the clinical diagnosis. So yes, thank you for this. About the medications so far are not yet in trial. They are used off-label as experimental drug, as let's say like a compassionate use, not yet inside a clinical trial. Some clinical trials are done by the Chinese, so the same medicine are in clinical trial, not in Italy, but in China, where of course they have bigger numbers, so it will be very interesting to see the result of those clinical trials. Yeah, you're welcome.
Thank you so much for the wonderful presentation. It was very, very important, especially for us who are in the clinical part of the management. But now, what do you advise for us with regards to what you have presented here, that currently now, most of these African countries, we don't have COVID outbreak. But in case we happen to have the cases and who present in the mild case, do you advise us to to manage them at the health facilities, or we just manage them at home like the way you guys do now?
For me, what I advise is what we were doing at the beginning. Until you have the capacity, the hospitalization is always better from an infection control point of view. Because at home, you never know. Anyway, at home, the person very rarely live alone. So the possibility to contaminate other people is higher. So until it's possible, I think that the hospital admission, or we can even find some compromise, because they don't really need, many of them, at hospital. They need a place to be isolated. So we can have maybe cheaper solution as a good compromise to provide a place where the person can be isolated and still receive food, receive the basic things. So maybe this can be a compromise, but I think until there is a capacity, the best is to isolate the person. I already said, but I think it's the most important take-home message is really for you to implement as much as possible the prevention infection control, because all of this mess where we are now should be avoided. And as I say, we made this in the hospital. It's very, I'm ashamed to say, but I'm just sharing with you because hopefully you will not do the same mistake. So all the effort, if I was the minister, I would put all the effort, 80% of the effort in prevention infection control, honestly, to try to don't reach this point where we are now. Yes, go ahead.
Oui, en fait, ma préoccupation, c'est un rapport avec les dispositions prises pour au fait, la population habitant l'Italie qui veut sortir de l'Italie. Apparemment, les dispositions sont prises pour l'entrée, mais du fait que l'Italie est affectée, est-ce qu'il n'y a pas de dispositions prises pour la sortie de la population ou de la communauté habitant l'Italie?
Oui. Okay, yes, I was talking with Osman before, and we were saying that probably if this workshop was 2-3 days after, I probably could not have joined, because just really 2-3 days ago, there were this measurement quite very strong for Italy. We never leave anything like this, that everybody should stay at home. Our schools are closed since 3 weeks. The shops still, some is open, but most of the activity are shut down. So really, our country is another country. I mean, everybody is at home, the one who can stay home. And the travel is only allowed for the one with, let's say, emergency reason, for some emergency work or some emergency situation. But the travel are really have been reduced a lot. Many European countries first start to stop the border. So, for example, I cannot go to France in this moment, and some African countries as well, they put restriction, or they put, like Zambia, normally I should be in quarantine. I got the exception because I'm here for this workshop, but normally the Italians are in quarantine here. So yes, there are restrictions. It's not like completely forbidden. There are exceptions, but it's greatly reduced. And really, we never saw a measure like that. I saw the video yesterday. The streets are empty with the car of the police saying, stay home, everybody stay home. It seems like a war. Right? It's quite scary. Yeah. There was another question? Or? Okay, so I don't know if you are still alive, first of all. No, because in theory, if you want, there was a last small exercise on infection control. But we have the time to do it?
We do.
But it's quite light, don't worry. So the best is maybe if you can divide 3 groups, 1, 1, 1. And you take, I give you 2 paper, and you have like 15 minutes to discuss. They are quite easy questions. And then in 15 minutes, group by group, each one say the answer to the question.